Welcome to NU 623 Adult Healthcare Unit 5 Presentation 2 on Thyroid Disorders. Please read the accompanying chapter in your text and review any links in the course module that is associated with this presentation. Hyperthyroidism is the overproduction, oversecretion, or overexposure of thyroid hormones, which has a profound effect on all bodily systems. It'll be very important that you fully read the epidemiology and pathophysiology section of your text and table 57.1 on page 881 for the many causes of this collection of disorders that is termed as hyperthyroidism. Graves' disease is the most common cause of hyperthyroidism and is an autoimmune disease. This is followed by subacute thyroiditis and toxic multinodular goiter, which have similar occurrence rates. Single toxic nodules only account for 3 to 5% of causes, but overuse of thyroid hormones can also put a hypothyroid patient into hyperthyroid as well. The presentation can be asymptomatic, or you could have symptoms from every body system. The likeliest complaints will be weight loss, palpitations, anxiety, insomnia, intolerance to heat, tremors, increased appetite, menstrual irregularities, and increased stooling or loose stools. They can also have a feeling of neck fullness or dysphagia if they have swelling in the neck area. On exam, you may see tachycardia, or if you do an EKG, you may see AFib or SVT. Elevated blood pressure may be seen. Patient might have tremors. Reflexes would be hyperactive. The skin would be moist and flushed. There could be an enlarged thyroid gland, or you could palpate nodules. It could be painful, but it may not be painful on the thyroid. Proximal muscle weakness is an issue, and muscle atrophy, and you may see some eye involvement such as lid lag, edema, and exophthalmos. Please read the objective section in the text because they do a very good job of differentiating the presentations for each form of hyperthyroidism. And also be sure that you were aware of the differences between the presentation of hyperthyroidism and thyroid crisis or storm, which can be fatal and requires immediate treatment. On your differential diagnoses, you can see that these are usually different forms of the hyperthyroidism that you are trying to tease out, as well as a pituitary adenoma and possible medication side effects. Be aware of the medications that can induce thyroid disease, such as amiodarone, because you're going to have part of your treatment plan is going to be screening for thyroid disorder with these patients. Initially, the first test you want to do is the TSH, or the thyroid stimulating hormone. It's a very sensitive screening test, and if it's abnormal, you can proceed to obtaining the thyroid hormone levels, free T4, which is thyroxine, and T3, which is triiodothyronine. Many labs are set up to reflex to these hormone levels if the TSH is abnormal. This is ideal for the patient because it saves another lab draw, but if not, many labs keep samples for several days, and all you have to do is ask them to run additional tests on the original sample. In overt hyperthyroidism, you should see a suppressed TSH with an elevated free T4 and possibly an elevated T3. A small percentage will have a normal free T4 but an elevated T3. In what we call subclinical hyperthyroidism, you will see a suppressed TSH, but the free T4 and the T3 will be normal. So they aren't necessarily quite to the point of being called purely hyperthyroid, but they're on their way. A CMP can be done. This you're looking for potassium wasting, hypercalcemia, or increased alkaline phosphatase. On your CBC, you may see a low hemoglobin and hematocrit or red blood cell count, which would indicate anemia, and you're doing this more to rule out anemia because of the clinical presentation. You might see a high white blood cell count, which can indicate either infection or inflammation. Plus, you would want both of these done baseline prior to starting any medications or treatments or doing further testing. An EKG might need to be done if you have an irregular rhythm or a rapid heart rate. So you're looking for AFib or sinus tach, or you're looking for an SVT, a supraventricular tachycardia. Depending on the H&P and the level of acuteness of symptomology, you could consider some other labs, or you could wait for initial tests to come back. What I would suggest is doing a CRP, or which is a C-reactive protein, or a SED rate, an ESR. If there is neck pain on exam, you want to evaluate for inflammation because of subacute thyroiditis. This will be elevated in that condition. TSH receptor antibodies, these are elevated in Graves, and when you do this test, this is confirmatory in most cases for a Graves diagnosis, and no further testing is needed. It's going to be negative for toxic adenoma and negative for multinodular goiter. Thyroid antibodies are not specific for Graves, but a positive result will help you confirm the autoimmunity of the thyroiditis. A normal or a mildly elevated antibody may be seen in subacute thyroiditis, but it's going to be negative in a toxic adenoma or a multinodular goiter. Ultrasound is where you're going to start if you have an enlargement or a known or suspected nodule in the thyroid. You need to determine if the swelling is intra or extrathyroidal. To help rule out a toxic adenoma, you're going to do that for any suspicious nodules meeting defining characteristics on ultrasound. They're going to proceed to a fine needle aspiration for those. And fine needle aspiration for nodules on ultrasound usually means that the nodule was greater than 1 centimeter, but there are other characteristics they look at as well. Any nodule greater than 4 centimeters has a high rate of malignancy, and a fine needle aspiration can have a false negative detection rate. So those patients, rather than going to fine needle aspiration, if you see a nodule that large on ultrasound, you should refer them to surgical management. They would likely do a surgery to remove that and biopsy it. There are two types of thyroid nuclear medicine tests that can be done. There's a thyroid scan, which determines the size and the shape of the gland, detects any lumps or inflammation to investigate the cause of the overactive thyroid. And then there's a radioactive iodine uptake test, which checks how the thyroid is functioning, and it determines why the thyroid hormone levels may be elevated. The scan is usually ordered when a physical exam or laboratory findings suggest that the thyroid is enlarged or has a nodule. If the labs are showing hyperthyroidism, the radioactive iodine uptake test can be ordered at the same time to evaluate the thyroid function. The radioisotope scan will show diffuse enlargement in a Graves' disease, and hot areas with suppression of surrounding tissue is usually seen with a toxic adenoma. If there's multiple hot and cold areas, you're looking at a possible multinodular goiter. And cold nodules might need ultrasound and fine needle aspiration for further delineation. On the radioiodine uptake test, increased thyroid uptake can be seen with a multinodular goiter, focal areas of uptake, or it could be even normal. Graves' disease is going to have a diffuse uptake, and a toxic solitary nodule will have a focal uptake. Low uptake on this test would suggest a subacute thyroiditis. Treatment consists of reducing the symptoms and attaining a euthyroid state, meaning the thyroid levels are within normal limits. Depending on the underlying cause and the severity of the symptoms, multiple types of treatments are available. Some are considered definitive treatment and some may require retreatment, and others are only offered for symptom improvement. So you can see the different forms of hyperthyroidism here and what the suggested treatment plan is for each. Decreasing thyroid hormone synthesis with antithyroid drugs includes PTU or methimazole, first line for most disorders. Radioactive iodine can be done, but this should be directed by the specialist because it can cause ablation of the thyroid and can actually worsen any ophthalmopathy that is going on with like a Graves' disorder. I want you to look at table 57.1 for drugs commonly prescribed for more information in your book. For symptom management, beta blockers are used to help control the tremors and the anxiety and the high heart rate. Propranolol is usually the preferred, but if your patient has some comorbids such as COPD, bronchospasm, or uncompensated heart failure, you may want to consider other medications. You could consider a calcium channel blocker in pulmonary disorders. Pain control and inflammation is necessary in subacute thyroiditis. This is going to depend on the phase of the disease. In hyperthyroid phase, they may not need any treatment unless it's very painful or impaired swallowing, or if they're having problems with nutrition because of impaired swallowing, or if they have severe thyrotoxicosis symptoms. When they get into the hypothyroid phase, they only need treatment if there's moderate biochemical levels, meaning their labs are off and they're symptomatic. So then they're going to be treated with levothyroxine. You need to be aware too that surgery is an option for some patients and sometimes is the only definitive treatment. They may have a total thyroidectomy or a subthyroidectomy depending on the underlying cause. It may be able to put them into remission if they have failed antithyroid drugs or radioactive iodine treatment. And then be aware of thyroid storm, a very serious condition, needs to be treated in an intensive care unit because patients may have accompanying sepsis or need respiratory support. They typically will have volume depletion and may have acquired CHF at that point in time. Be aware of some of the patient education that needs to be done with your patients to help them with their self-care. It's on page 888 to 889. Follow-up is going to be very dependent on the choice of treatment and the patient response, but it's going to be done in tandem with a specialist. So long-term evaluation needs to happen because there is a recurrence of hyperthyroidism usually. The rate of relapse, if they do not have definitive treatment, can be high. They also could suffer from subsequent development of hypothyroidism regardless of the treatment choice. So monitoring the TSH and the free T4 every 4 weeks until they become euthyroid is standard, and then every 3 to 6 months while they're on an antithyroid drug. If they had radioactive therapy, you'd repeat the TSH at 6 weeks, 12 weeks, and 6 months, and then annually. A baseline CBC needs to be done to be repeated if agranulocytosis is suspected. And liver function tests are done. There is a rare hepatic abnormality with the antithyroid drugs, but you need to monitor for it. See the management section of your text for more information on the follow-up of each particular disorder. In subclinical hyperthyroidism, if they're not being treated currently with any medications, you're going to monitor them every 6 months because they're at risk for cardiac disorders and low bone density. Referrals can be various. Surgeon may be needed if a thyroidectomy is the form of management selected. You're going to send them to the emergency department for a thyroid storm, endocrinologist for the management of patients who either don't respond well to initial treatment or require more serious treatments such as radioactive ablative therapy, or if they're pregnant or they have subclinical disease that's not being treated. And then ophthalmology should be conferred with because patients can have a high degree of eye disease with Graves' disease, and they're going to want to be looked at annually for that. Hypothyroidism is a disorder that you're likely going to see more of. It's very common. It can be a congenital condition or acquired, and it can have various causes, including autoimmunity, which is Hashimoto's thyroiditis, and that's the most common in the United States. There can also be a subclinical type of hypothyroidism, and thyroids that get destroyed either by medications or surgery will show hypothyroidism, or if there's an iodine deficiency, which is not very common in the United States. See table 57.4 on page 890 of your book for more information. Primary hypothyroidism results from the thyroid gland dysfunction itself. A central hypothyroidism can be classified as either a secondary hypothyroidism, which comes from the pituitary gland not secreting enough TSH, or a tertiary hypothyroid is where the hypothalamus fails to secrete enough thyrotropin releasing hormone, or TRH, and that fails to activate receptors in the pituitary gland. And there's a little bit different workup for each, but the clinical presentation is pretty much the same for both of them. There's an insidious onset usually for the symptoms, so it may take several trips to the doctor's office to try to figure out what is exactly going on. But the symptoms can also vary with the duration of the illness and the severity. So I do want you to look at page 57.5 or table 57.5 on page 892 for the clinical presentation. The more common complaints and symptoms that you will see are listed here on the slide. And as far as your differential diagnosis, you can see that there can be different types of hypothyroidism, as I already alluded to, but there are disorders outside the thyroid that can also be contributing to the symptoms. And you'll have to tease those out with your H&P and your diagnostic tests. Again, your initial test you're going to do is your TSH, and if this is elevated, it is sufficient to diagnose primary hypothyroidism. If you want confirmation, you can get a free T4, and if it is low, that confirms the primary hypothyroidism, but it can be low normal to normal in early disease. So your TSH is your number one option. If the TSH is low, normal, or mildly elevated, and you also have a low free T4 and T3, then it's pointing more towards a central type of hypothyroidism. If your TSH has a mild elevation and a normal free T4, then you're looking at a subclinical hypothyroidism. You're going to want to also check cholesterol on these patients because frequently the LDL and the triglycerides are elevated due to the thyroid issue, and quite honestly, a lot of times when the thyroid is treated, these come back down to normal. On your CMP, you're checking electrolytes, kidney function for impairment. On your CBC, you're checking anemia, and that could be because you have your one of your number one symptoms is going to be fatigue. On the UA, if it shows protein, then you're looking at some possible renal impairment. Anti-thyroid peroxidase antibodies, they are going to be elevated in the autoimmune thyroiditis like your Hashimoto's. Ultrasound and radioactive scans are not necessary unless you have a suspicion of nodules or infiltrative disease on exam, then you would do those. But you can diagnose, like I said, your primary hypothyroidism with just your TSH. An EKG may be done too because of some of the symptoms involved with hypothyroidism, such as the bradycardia. Management consists of replacing the thyroid hormone, and what you want to do is normalize the TSH. When you order a thyroid replacement medication, you need to make sure that you consistently order the same brand for that patient. Don't switch them around. In overt hypothyroidism, you can see here what your levothyroxine dosing is depending on whether they are healthy or have coronary artery disease or their age. When you adjust your levels after your 6 to 8 week time frame of being on the medication, you're going to repeat a TSH and a free T4, and your adjustment is going to be by 12.5 to 25 micrograms during that time if you have not controlled the hypothyroidism well enough in overt. But in subclinical, you're going to adjust at a 25 to 50 microgram level every 6 to 8 weeks. And consider too that you did start levothyroxine at a lower dose for subclinical hypothyroidism if you chose to treat the subclinical. And subclinical is not always treated, as I said earlier, but if the patient has a TSH greater than 10 and they're symptomatic, most providers tend to treat. Central hypothyroidism, your goal again is going to be to normalize your labs, but this is going to be targeted towards the free T4, not the TSH. You're going to assess for and you're going to treat any adrenal hormone deficiency before you replace thyroid hormone with central hypothyroidism. And you are going to use levothyroxine as well for your replacement. Myxedema coma, I want you to take a look at your text on page 896 for that. You need to read about that and understand the signs and the symptoms and the treatment plan for this, because it can be a life-threatening complication of untreated hypothyroidism. And then patient education is extremely important for patients who are on thyroid replacement hormones. They need to understand how to take those meds. That needs to be done on an empty stomach in the AM, and there needs to be a 4-hour window before or after any other meds are given that could interfere with absorption. And some of the medications that are more common that interfere are your PPIs, calcium supplementation, or iron. With initial treatment, you're going to see your patients every 4 to 8 weeks, either after the initiation of the medication or with any dose changes. There is a narrow therapeutic window for the labs, and careful titration of the dose is needed so that you avoid over-treatment, which would make the TSH driven down too low and be undetectable. And if you're under-treating, your TSH would still be above 10. So always ask your patient when you're repeating laboratory work if they've been compliant and they've not skipped any doses in the last week. If that has been the case, then delay the testing until they have had at least 7 days of consecutive medication dosing. Otherwise, you might get a false TSH, a false high TSH, and you would overcompensate that with too high of a dose increase, and you could put them into hyperthyroidism. You want to make sure that you monitor for all drug side effects and comorbid complications too. And again, when they have the subclinical that is not being treated, you want to reassess them every 6 to 12 months to see if it's time to start medication and to look for comorbid conditions. Now, With referrals, endocrinology, if they have any symptoms of myxedema, cardiac disease, central hypothyroidism, or after they start treatment, they develop thyrotoxicosis symptoms, or they have unusual or confusing labs, or pituitary disease, they're pregnant or postpartum, or they're on medications such as lithium or amiodarone, you do want endocrinology involved in that case. If there's evidence of a myxedema coma, that goes right to the ER because it's going to require high-dose IV levothyroxine replacement. Thyroid cancer is actually pretty rare in the United States, but it can be a primary or a metastatic type of cancer. It can be a slow-growing cancer or it can be very aggressive. And typically it's going to present in the same way as a lot of your other thyroid disorders, like as a painless lump or a full feeling in the neck. Could be difficulty swallowing or hoarseness, or even coughing up blood or swollen glands. On exam, you would probably feel a thyroid mass or a nodule, and if so, it would be firm and fixed and non-tender, but neck pain is a late symptom of thyroid cancer. There could also be some swelling or nodules or tenderness of the surrounding structures and the cervical spine. The differential diagnosis is obviously to make sure if it's a malignant or a benign type of disorder, and if it requires thyroid replacement treatment such as a hypothyroidism, or if it's a hyperthyroidism, or if it's not related to the thyroid at all and it's a regional lymphadenopathy. So your initial test is going to be your TSH, thyroid function test, and they're normally going to be normal unless a thyroiditis is also present. And then an ultrasound can be done to confirm nodules, but it's unreliable to determine malignancy. And radioactive iodine uptake can be done to determine the function of the nodules. A higher uptake is a better prognosis because that means the tumor would likely respond to radioactive iodine treatment. Other tests that can be done is a fine needle aspiration. So this is where you're going to biopsy any suspicious nodules. There's pretty good specificity and sensitivity to determine malignancy as long as the nodule was appropriate for biopsy and not too large. But if there is not a diagnostic evaluation after that test, then a surgical lobectomy can be done for an open biopsy and confirmation. CAT scan or MRI can be done when there are large or recurrent tumors or a suspected spread outside the thyroid is an issue. Thyroid function tests, like I said, are usually normal unless thyroiditis is also present. And calcitonin can be elevated if there's a medullary cancer. And genetic tests can be done for familial endocrine type cancers as well. Management options include surgery, radiation, chemo, radioactive iodine treatment, and if the thyroid has been taken out or ablated completely, then thyroid hormone replacement would be needed to perform the necessary bodily functions. After the thyroidectomy, a follow-up is going to be done by the specialist, and it's usually in 6 to 12-month intervals with the endocrinologist. They're followed closely for the first 3 or 4 years because of recurrence of cancer, and follow-up testing for thyroid hormone replacement would need to be done. Endocrinology should be consulted for any neck swelling suspicious for malignancy. Early referrals for nodule evaluation and treatment is important because cancers less than 2 centimeters usually have not spread. Surgeons would be consulted, a head and neck surgeon specifically, for a lobectomy or any radical neck surgery, and oncology may need to be referred to if you need cancer treatment, and this could be medical and or radiation oncologist. I highly encourage you to read through the whole chapter in your book for the thyroid disorders, because there is a lot of information in there. Too much to put on a slide presentation, but also extremely important, and these are things that you are going to see very frequently in clinic. Also check any resources that are in the module in your course and review those that can help you with your understanding of these disorders.